Now we will discuss hyperadrenocorticism or Cushing's disease. It is a metabolic disease that is caused by chronic excess cortisol in blood. So before we discuss about the Cushing's disease, we should know the basics. For basics, we should know what are the functions of cortisol, and we should know the HPA axis. I will again repeat the HPA axis that we covered in Addison's disease. Hypothalamus secretes CRH, corticotropin releasing hormone that acts on pituitary. This pituitary gland will then produce ACTH. This is very, very important. ACTH is very important for Cushing's disease. So remember, pituitary secretes ACTH that acts on adrenal gland, and adrenal gland then releases cortisol. And again, there's another very important thing, that this cortisol will have a negative feedback on pituitary and hypothalamus. So what's important for us to know is pituitary gland secretes ACTH that acts on adrenal gland, that will make adrenal release cortisol, and this cortisol has a negative feedback effect on pituitary gland. So if there is more cortisol, it will send a negative feedback to pituitary. Hence, the ACTH levels will decrease. Another important thing before we start reading about Cushing's disease is functions of cortisol. What are the normal functions of cortisol? We can understand the disease better only if we know what cortisol normally does. Only then we can think about the effects of excess cortisol. So cortisol is a stress hormone. It increases production of glucose in the liver. It also decreases glucose uptake by the cells. So that means blood glucose levels will be increased. It also increases breakdown of lipids, fats, proteins to produce more energy. Very important point is it also increases accumulation of glycogen in the liver, so that the glucose produced is also being stored in the hepatocytes. So it also encourages liver to store glycogen. Another important point related to the liver is cortisol stimulates enzymes in the hepatocytes that will cause liver hypertrophy, which means that it will help liver to increase in size. It will lead to hepatomegaly, so that the liver can compensate for the increased metabolic demands. See, the liver needs to produce more glucose, right? It needs to store glycogen. So liver needs to do a lot of work. And for that, cortisol also prepares the liver cells to increase in size. That means it will lead to the hepatocyte hypertrophy. The liver cells will increase in size. We already discussed that cortisol will stimulate breakdown of fat, protein, etc. So it stimulates lipolysis. Lipolysis means breakdown of fat. But there's another important point, that high chronic cortisol levels. So short term it will stimulate lipolysis, but long term it will also lead to redistribution of fat to certain areas like abdomen and neck. So there will be more fat stored in abdomen, in neck, if there is high levels of cortisol chronically, while depleting peripheral fat stores. So just remember that excessive long-term cortisol will lead to increased fat in abdomen. Cortisol also increases sensitivity of blood vessels to catecholamines. So it will help increase the BP, so that the blood is available to all the vital organs during stress. Cortisol suppresses the immune system, so it will lead to immunosuppression. It will also suppress the osteoblast activity. Osteoblasts are the cells that form the bone. On the other hand, it will increase osteoclast activity so that there is more bone breakdown. Basically, what it is trying to do is that it is trying to release calcium from the bones into the blood, making the bones more porous. Why? Because in situations like stress, since it is a stress hormone, it will tend to make calcium available in blood, so it's readily available for functioning of muscles, for nerves, neurotransmitters, enzymes, etc. It doesn't care about the bone during stressful period. It is trying to make more calcium available in the blood. Now, cortisol also delays wound healing and decreases collagen synthesis. And this will eventually lead to fragile skin, increased bruising. Another point related to the skin is that cortisol stimulates melanin production. It also inhibits hair follicle cycle and arrests hair growth in a resting stage. We read the same point in case of hypothyroidism as well. So it also inhibits hair cycle. Last two random points related to cortisol but that are important are: cortisol inhibits ADH hormone, antidiuretic hormone, also known as vasopressin. Now, ADH hormone will do what? It's antidiuresis, means it will prevent urination. And if cortisol inhibits this, that means cortisol favors urination. Cortisol will lead to diuresis to prevent excessive water retention. Last point related to cortisol is that cortisol favors clotting, which means it prevents bleeding. How? It increases platelet function, it increases clotting factors, it decreases fibrinolysis. Fibrinolysis is breakdown of clots. So overall, it favors clotting. You can also link this point with stress. During stress, there is a chance we bleed, so it will help clotting and prevent bleeding. So all these points are not important for Navle, but it creates a basic idea and it helps to understand the disease better, because if we know what are the functions of cortisol, we can easily figure out what happens when there's excess cortisol or when there is deficiency of cortisol. It's very important that we understand these functions. No need to cram them for Navle. And any extra cortisol in the blood is directly spilled into the urine. So the kidneys will spill it into the urine and hence cortisol will be excreted out in the urine, the extra cortisol. Now all these points will make sense later on when we read clinical signs, when we read the diagnostics or the treatment. Let us start with Cushing's disease. Cushing's disease can be classified into three categories. First one is pituitary dependent Cushing or pituitary dependent hyperadrenocorticism, which is PDH. Second one is adrenal dependent ADH. Third one is iatrogenic Cushing's. So number one, PDH. In this case, there is tumor of the pituitary gland, and it is the most common cause of Cushing's in dog and cat. It is said that 80% Cushingoid dogs and cats have PDH. So in this case, there is pituitary adenoma, which is a benign tumor of pituitary gland. So what will happen? If there is a tumor of pituitary, this means the pituitary will secrete excess ACTH, right? ACTH, now this ACTH will keep stimulating the adrenal cortex. So the adrenals are overactive. They have to function more. So they are overactive. This will lead to bilateral adrenocortical hyperplasia. In simple terms, it means that both the adrenal glands will increase in size. There will be bilateral enlargement of adrenal glands because of excessive ACTH. Now this is very important point. You really need to understand the concept of what happens in each case. The second one is adrenal dependent In this case, there is a tumor of adrenal gland, as the name suggests. And when there is a tumor of adrenal gland, it will only be present in one adrenal gland that is affected. So there will be unilateral adrenal tumor. Now this can be adenoma or carcinoma, which means it can be benign or malignant, both. It can be either of the two. So in ADH, there is unilateral adrenal tumor. This means there will be unilateral enlargement of adrenal gland. One adrenal gland will be increased in size. As a result, what will happen? It's producing a lot of cortisol, so that will send a negative feedback mechanism back to the pituitary. The excessive cortisol that is produced by the tumorous adrenal will send a negative feedback to the pituitary that you need to stop making more ACTH. So this tumorous adrenal does not care about how much ACTH is produced. It does not rely on ACTH. It doesn't care. So what will happen is the opposite adrenal gland will atrophy. This is very important. Why? Because the opposite gland is not being stimulated by ACTH. All the ACTH has been suppressed by the adrenal gland that is tumorous, that's already too big in size. And that tumorous adrenal does not care, it doesn't need ACTH, but it's also messing up for the other adrenal gland, so the other adrenal gland will atrophy. So what happens in this case is one adrenal is too large, the one that has the tumor, the other one atrophies. So there's atrophy of one adrenal gland. Last one is iatrogenic Cushing's. It happens when we give excessive or prolonged corticosteroid injections. So it's basically drug induced. Now this exogenous steroid that we are giving, it mimics high cortisol. It will act like the body, because the body already has enough cortisol, because we are exogenously injecting that steroid which acts like a cortisol. This will send a negative feedback to the pituitary, and hence ACTH will be suppressed. Now if the ACTH is suppressed, it will lead to lack of stimulation for both adrenal glands. So what will happen with time is both the adrenal glands will atrophy because they are not being stimulated by ACTH. ACTH is required for adrenals to produce cortisol, but in this case there's already high amounts of cortisol that is being exogenously injected through drugs. So what will happen is there will be no ACTH. Eventually both the adrenal glands will atrophy. So I will quickly repeat what happened in pituitary dependent PDH was both adrenals were enlarged and there was no atrophy. In ADH, the adrenal dependent one, the one with the tumor, the adrenal with the tumor, one of them was enlarged, there was unilateral adrenal enlargement, and the other one was atrophied. And in the iatrogenic one, both are atrophied, none of the adrenals are enlarged. That's all about the categories of Cushing's, and if we understand this properly, then it will be easy to understand the diagnostics or the treatment part. So it's very important to remember all these points. Now the clinical signs of Cushing's. The way I've remembered it is 5 P's. So there will be 5 signs starting with P. There will be skin signs, and there will be third weakness and lethargy, which is the general signs. So 5 P's, skin, third is general, weakness and lethargy. Now the very important clinical signs are PU, PD and polyphagia. Why does polyuria occur in case of Cushing? Because as we remember, cortisol inhibits the function of ADH, which is antidiuretic hormone. So excessive cortisol will lead to polyuria, and polyuria will obviously lead to increased thirst. Hence polyuria, polydipsia are seen in this case. plus polyphagia. Now, why does polyphagia occur? The reason is cortisol decreases the uptake of glucose by the cells. The cells are starving. The cells do not get glucose or any source of energy. So that is why even if there is increased blood glucose, the cells are starving and hence animal will tend to eat more. Next very important point is pot-bellied appearance. Now there's a pot belly. Why? Because there's abdominal distension. The reason is cortisol will lead to muscle weakness because it breaks down the proteins. That is very important. Cortisol breaks down proteins, fat, etc. to release more energy, and hence muscles will be weak. Plus, as we know that the liver is trying to store glycogen, this will lead to hepatomegaly. So the liver size is enlarged, the muscles are weak, that will lead to abdominal distension and pot belly. Very important. Characteristic hallmark of Cushing disease. Another clinical sign is panting. So panting, why does panting occur? Because if you remember, I previously mentioned that cortisol will lead to redistribution of fat. Excessive cortisol chronically will lead to increased fat deposition in the thorax. So there's increased abdominal and thoracic fat, plus obviously if the muscles are getting weak, the respiratory muscles are weak too. Third reason why panting is occurring is because the large liver is pushing against the diaphragm. And why is the liver large? Because there's hepatomegaly. Everything is linked. So the 5 P's that I mentioned were PU, PD, polyphagia, pot belly, and panting. Next up, the skin signs. So hyperpigmentation. Why does hyperpigmentation occur? Because when we discussed the function of cortisol, we said that cortisol increases melanin production. So obviously there will be hyperpigmentation. Bilaterally symmetrical alopecia, very, very important. Why? Because there's poor hair growth. If you remember, cortisol also inhibits the hair follicle cycle. So it disrupts that. That will lead to alopecia, bilaterally symmetric alopecia. There was a similar clinical sign in case of hypothyroidism too. So we need to link all the points. In hypothyroidism too, there was bilaterally symmetric truncal alopecia. That was special about hypothyroidism, and the reason was the same, that the hair follicle cycle was disrupted. So I will repeat again. In case of Cushing, the skin signs are hyperpigmentation, bilaterally symmetric alopecia, thin or fragile skin. Why? Because cortisol decreases collagen synthesis. There's another point that is different. It is calcinosis cutis. This is hard, chalky, raised plaques that are present on the skin due to abnormal calcium deposition in skin. So this is an extra point, not hallmark, but it is related to the skin. So there are 4 skin related points: hyperpigmentation, bilaterally symmetrical alopecia, thin fragile skin, and calcinosis cutis. Now in case of pituitary tumors, that is PDH, CNS signs can also be seen. But the most important signs were the 5 P's: PU, PD, polyphagia, pot belly, and panting. Second one was skin signs, that were hyperpigmentation, bilaterally symmetric alopecia, thin fragile skin, and calcinosis cutis. The last one is weakness and lethargy. That is enough for Navle. Next is the blood picture. First one, very, very important point that will be seen in the question is stress leukogram. What is stress leukogram? You can remember it with NMILED. N mild. That's how I remember it. So NMI means the neutrophils and monocytes are increased. LED, the lymphocytes and the eosinophils are decreased in number. So they will give you the number of, they will give you the CBC, and you can easily figure out a stress leukogram, and it is characteristic, again, hallmark of Cushing's disease. Another hallmark sign, just special, unique to dogs, is increased ALP, alkaline phosphatase. So this enzyme will be increased. Why? Because cortisol induces isoform or isozyme of ALP hormone known as CALP. What does this mean? That first of all, isozyme is the different form of same enzyme. So CALP stands for cortisol ALP. Cortisol simply induces another form of this ALP hormone, and hence it can be detected in blood, and it's only unique to dogs. So there will be very high amount of ALP levels in the blood. Remember this. Next point is increased ALT. ALT is alanine transaminase. ALT is the enzyme that is only increased in case of hepatocellular damage or hepatocyte injury. That means when there is a damage to the liver cells, this enzyme will be released. So why is ALT increasing in case of Cushing's? Because there is hepatocyte damage. There is swelling in the liver due to glycogen accumulation. That is why ALT will also be increased. Another thing, hyperglycemia will be seen in this case because cortisol increases blood glucose. Other than that, cortisol also increases fat breakdown, as we already know, so it will lead to hypercholesterolemia. There was this thing mentioned in vet prep that in Cushing's there is increased SAP. SAP is basically serum alkaline phosphatase. It's just another name for ALP. So increased ALP or increased SAP is unique to dogs, and it is especially seen in case of Cushing's disease. The next point for blood picture is there will be decreased BUN. BUN will be decreased because there is polyuria, and polyuria means excessive urine production. So this excessive urine production will lead to increased clearance of the BUN, creatinine and urea. So these things will be decreased in blood. Next very important point mentioned in vet prep was high cortisol suppresses pituitary secretion of TSH, thyroid stimulating hormone, and it also increases T4 metabolism. So basically it will decrease the T4 levels, the thyroid hormone that is in the blood, the form of the hormone that we studied that is circulating in the blood. Cortisol will tend to decrease it. So in Cushing's, there will be decreased T4 levels. Next, very, very important, most important from NAVLE point of view are the specific diagnostic tests. There are two categories of diagnostic tests. First is screening test that just suggests the presence of Cushing's. So these tests are just to rule out if Cushing disease is present or not. And the other category is tests that distinguish between PDH and ADH, which means first you confirm the presence of this disease through the screening test, and then figure out the cause of Cushing's disease, whether it's because of pituitary or adrenal or due to iatrogenic causes. So first, the screening tests. There are 3 screening tests: UCCR, second one ACTH stimulation test, third is LDDS. And the tests that distinguish PDH from adrenal Cushing's are, first one is HDDS, second is endogenous ACTH levels, third is abdominal ultrasonography. I will explain each one of them. First of all, the screening tests. Number 1 is UCCR. It stands for urine cortisol creatinine ratio. So it measures the ratio of cortisol to creatinine in the urine. So higher this ratio is, that means higher the cortisol levels are in the urine. This just suggests there's Cushing's disease because there is excessive levels of cortisol. Now, why are we mentioning creatinine here? Creatinine is measured simultaneously, side by side, so that we do not have misleading results. So if the urine is diluted or concentrated, that sample can give misleading results. So cortisol to creatinine ratio will help understand the concentration of cortisol in the urine, regardless of the dilution or concentration of the urine. Basically, more the UCCR, higher the cortisol, that means it is more likely to have Cushing's disease. So most Cushingoids will have increased UCCR, but it is also increased in case of stress and other diseases, so it will give false positives. And it is not used to diagnose but only to rule out Cushing's disease. That means if the UCCR levels are not increased, then it's likely that the animal is negative for Cushing's. So levels of less than 13 microgram per deciliter suggests negative for Cushing's. Next test is ACTH stimulation test. We also read this in case of Addison's, but here it's a bit different. So it is a screening test to diagnose spontaneous Cushing, which means spontaneous means it is not iatrogenic. It is occurring naturally. It's either PDH or ADH. It is less sensitive than LDDS and it is expensive, so it's a second choice. It does not distinguish between PDH and ADH, but it will distinguish the iatrogenic Cushing's. So basically, it will tell you if the animal is suffering from iatrogenic Cushing's. It won't differentiate between the pituitary or adrenal cause, the first two categories. So in this ACTH stimulation test, we are measuring the cortisol levels in the morning before giving ACTH. The ACTH, we then give exogenous ACTH in the form of ACTH gel or an IM injection. That is not important. So we measure cortisol levels again after giving ACTH. So what is expected? If you give ACTH exogenously, it will stimulate the adrenal glands to produce more cortisol. So the cortisol level should rise a little bit in normal animal. So the observation or test results are that in the normal animal, post stimulation, there is an increase in cortisol levels, but it's within the normal range. So it's roughly 6 to 7 microgram per deciliter. It means it increases, but not too much. But in iatrogenic, what happens? So in iatrogenic Cushing's, as we already know, adrenals become so suppressed by chronic administration of steroids that they stop producing cortisol entirely because they are atrophied. So in this case, what will happen? No matter how much ACTH there is in the body, or no matter how much ACTH we exogenously inject, there will be no increase in the cortisol levels in case of iatrogenic Cushing's. So there will be a flat line. The levels will be less than 5 microgram per deciliter. This is very important to understand. Now next is PDH. What will happen in PDH? Both the adrenals are hypertrophied. Means they are large in size and they will over respond to ACTH. The cortisol level was already high before ACTH administration, but after that it will even be higher because both the adrenal glands are overactive and enlarged. They are overworking. So in this case, the post stimulation cortisol levels will be very high. They will be more than 24 microgram per deciliter. Next is adrenal Cushing's. What will happen in adrenal Cushing's? If you remember, there was one neoplastic or tumorous adrenal gland. So this neoplastic adrenal will over respond to the ACTH again. It doesn't care about ACTH. It will produce very high amount of cortisol, which actually means that the neoplastic or tumorous adrenal was already maximally secreting cortisol. So when you exogenously administer more ACTH, it will rise even more. So a quick summary: in Cushing's positive animals, there is marked increase in cortisol for both PDH and adrenal Cushing, ADH. PDH and ADH will have very high amount of cortisol after ACTH stimulation test, but in the case of iatrogenic Cushing, there will be no increase. There will be a flat line because the adrenals have atrophied. They cannot respond well to the stimulation. The stimulation is through ACTH. So with this test, we can know if there is iatrogenic Cushing's or if there is PDH or ADH, but it won't help differentiate between PDH and ADH. We cannot be able to figure out the cause of Cushing. The last screening test, the third one, is LDDS, low dose dexamethasone suppression test. Dexamethasone is a synthetic cortisol, so it will obviously act like cortisol in the body. LDDS is diagnostic of choice for Cushing's. It does not again differentiate between PDH and ADH, and it does not reveal iatrogenic Cushing. So what will happen in this case is you will measure the amount of cortisol before administering dexamethasone. Then we need to measure the cortisol levels 4 and 8 hours after injecting dexamethasone. In dogs, I will tell you the dose rate. You don't need to remember this. In dogs, the dose at which we give dexamethasone is 0.01 mg per kg, and for cats it's 0.1 mg per kg. It's given through IV route. So what happens is we give dexa and then we measure cortisol levels 4 and 8 hours later. So what will happen in a normal animal? We administer dexa that mimics cortisol, so it will act like cortisol, and obviously it will send a negative feedback to pituitary, which will decrease ACTH secretion. And this ACTH means if the ACTH secretion is decreased, that means there is suppression of adrenal glands. So please try to understand the suppression point. The negative feedback will lead to decreased ACTH secretion, and that will suppress the adrenal glands that you need not to produce more cortisol. So now it's a bit tricky but very important to understand what happens at 4 and 8 hours. What are the findings? So first is normal animal. So once you give cortisol or dexa exogenously in normal animal, the adrenals will be suppressed because it will send a negative feedback to the pituitary. All right. So at 4 hours and 8 hours, there will be suppression. So just remember suppression of adrenal glands, which means adrenals need to stop making more cortisol. Now what happens in case of PDH? In case of PDH, at 4 hours, there is suppression. There is decreased cortisol levels. Why? Because this low dose dexamethasone will cause partial suppression. There is transient decrease in the cortisol levels. Some cells of pituitary will temporarily respond, causing initial suppression. But the problem here is PDH is pituitary tumor. So in the beginning at 4 hours, some of the pituitary cell will fear that, oh, we need to stop, right? We need to suppress the adrenal and we need to decrease cortisol. But what will happen at 8 hours? Since it's a tumor, the cortisol levels will rise back up because the pituitary tumor cells will escape the inhibitory effect of dexamethasone. So at low dose, at 4 hours in the beginning, the low dose of dexa was enough to suppress the adrenal gland, and hence there was decreased cortisol levels just for a while. But at 8 hours, what happens is eventually the cells remember that, oh, we are tumorous and we have the power and we need not to care about the suppression. So there will be no suppression at 8 hours. This mechanism is known as the escape pattern, where some cells temporarily respond to the negative feedback, but eventually they cannot sustain it for long. So they escape, and at 8 hours, they are back at the same bullshit. So they will not care. So there will be no suppression at 8 hours. Lastly, in case of ADH, what will happen? There will be no suppression at all. Why? Because the adrenal glands are independent of ACTH. They do not care about anything because the adrenal gland is tumorous itself. So it is secreting cortisol autonomously. So there will be no adrenal suppression or no decrease in cortisol levels at 4 or 8 hours. So I will summarize it again. In normal animal, at 4 hours, there will be suppression, and obviously there will be suppression at 8 hours as well. In PDH, there will be suppression at 4 hours, but no suppression at 8 hours. And in ADH, there will be no suppression at all for 4 and 8 hours. And by suppression, I mean the decrease in the cortisol levels. So Vet Prep mentions that the cortisol levels should be less than 1.4 microgram per deciliter. They should decrease to less than 1.4. And if in case there is no suppression, the levels are more than 1.5 microgram per deciliter. Now I will tell you a basic point here. They said that in case of LDDS, it does not reveal iatrogenic Cushing's. Why? LDDS, basically, this test only measures the endogenous cortisol. It will not give the results on the basis of the dexamethasone that we are giving. It will only measure the cortisol that is produced by the adrenal glands in the body. So what happens is, say the animal has iatrogenic Cushing, we give exogenously. So the cortisol levels will increase in the body, but that is exogenous. That is not produced by the adrenals. And in case of iatrogenic Cushing's, if you remember, both the adrenal glands are atrophied. So they will not be able to produce cortisol. That is why LDDS does not reveal iatrogenic Cushing's, because the endogenous cortisol levels are chronically low in these patients. So it's useless. LDDS is only for PDH and ADH, not for iatrogenic. Again, please remember, it's the diagnostic of choice. It's very important. Now we're done with most of the tricky part, and we just finished the screening tests that were UCCR, ACTH stimulation test, and LDDS. Now we will read about the tests that distinguish between the pituitary and the adrenal Cushing's, the PDH and the ADH. The first one is HDDS, high dose dexamethasone suppression test. In this case, it is similar to LDDS, but the difference is that you give 10 times the dose of dexamethasone. So if it was 0.01 mg per kg dexa in case of dogs and 0.1 mg per kg dexa in case of cats, in this case the dose is 0.1 mg per kg dexa for dogs and 1 mg per kg dexa for cats. We need not to remember the dose, but the idea is that there is a large dose of a high dose of dexa given. Hence the name high dose dexamethasone suppression test. So what happens in this case is the procedure is same as LDDS. It's just the difference in the dose and the results will be different too. So again, iatrogenic is not revealed in this case. So we just care about PDH and ADH. And this test will help to differentiate between PDH and ADH. So it will tell you the cause of the Cushing, whether it's due to pituitary or due to adrenal. So when we measure cortisol levels after administration of dexamethasone at 4 hours, what happens is the high level of dexamethasone causes adrenal suppression, complete adrenal suppression. This is important in PDH, which means there will be no escape pattern as was seen in LDDS. So we measure the results at 4 hours. We don't measure it at 8 hours at all. So what happens at 4 hours is in PDH, this high amount of dexamethasone is enough to suppress even the tumorous cells of pituitary. So if you remember in LDDS, what happened was first the pituitary was suppressed, which means it took the negative feedback and it suppressed the adrenals. It said that, okay, you need to stop making more cortisol. And then at 8 hours, again, the suppression was lifted. The suppression on the adrenal glands was lifted and the pituitary stopped caring. But this high dose forces the pituitary gland to decrease the amount of ACTH forever. So there will be suppression at 4 hours, at 8 hours, it will be present basically. While in case of ADH, the adrenal tumor case, there will be no suppression at all, because the tumorous adrenal is autonomously secreting cortisol. So what you need to do is, first we need to look at the screening test. We need to screen the animal. We need to test if the animal has Cushing or not. Once we have done the screening, we can go for HDDS, because this HDDS, once we know that the animal has Cushing's, then this HDDS will help us reveal the cause of Cushing. If the cause is PDH or ADH, if the cause is pituitary or adrenal. So I will summarize. In HDDS, what happens was at 4 hours, the cortisol levels or the suppression of adrenal in normal animal, it will be present because the DEXA will send a negative feedback to the pituitary and normally pituitary will suppress the adrenal. So normally there will be suppression. In PDH, there will be suppression because this time there is high dose of DEXA, and in adrenal Cushing, there will be no suppression. So PDH, suppression present, adrenal, no suppression present. That's how you differentiate between PDH and ADH, and this is a very, very important question for NABLE. Name the diagnostic test that is used to distinguish between PDH and adrenal Cushing, that is HDDS. The next two tests are endogenous ACTH and USG. They're very easy. Endogenous ACTH, you measure the endogenous levels of ACTH hormone, the hormone that is produced by pituitary. So obviously, in case of PDH, there will be high amount of endogenous ACTH because there is a pituitary tumor which is producing excessive ACTH. So it's very simple, this test. PDH will have high ACTH levels, more than 50 microgram per deciliter. And on the other hand, the adrenal dependent or ADH will show ACTH levels less than 50. So it will be less than 50 for ADH, PDH more than 50. Very simple. Last diagnostic is USG, ultrasonography of the abdomen. If on ultrasonography you see that there is unilaterally enlarged adrenals, that means only one adrenal gland is increased in size, that means it is ADH or adrenal tumor. If there is bilateral enlargement, then it is PDH, of course. Done with the diagnostic tests. The screening tests were UCCR, ACTH stimulation test, and LDDS, and the tests that distinguish PDH from adrenal Cushing's after we have screened for the disease. There are 3: HDDS, endogenous ACTH levels, and abdominal ultrasonography, and we're done with the diagnosis. Now we're left with the treatment part. So first of all, treatment of PDH. So in case of PDH, in pets, surgery is not recommended. Brain surgery is not recommended at all. So you have to rely on drugs. And remember the name of the drugs. There are 2 drugs, mitotane and trilostane. Mitotane is cytotoxic to the zona fasciculata layer, which produces the cortisol, most of the cortisol. So it is used for treatment. It can be used for the treatment for PDH and adrenal Cushing's, where the surgery is not a good option. So for PDH, surgery is not recommended. Hence, you have to give drugs only, mitotane and trilostane. It's important to remember the mechanisms of these drugs as well. Trilostane, on the other hand, is safer alternative. It is a competitive inhibitor of beta HSD. Beta HSD means beta hydroxysteroid dehydrogenase enzyme. It is an enzyme involved in the synthesis of steroids, and all these adrenal hormones are steroids basically. So trilostane will inhibit the beta HSD enzyme. This enzyme, it's very important for NABLE as well. It is not yet approved in US, but it's drug of choice in Europe, trilostane. So for PDH, the treatment of choice is mitotane and trilostane. Next is ADH, the adrenal Cushing's. The gold standard treatment for adrenal tumor is surgery. So surgery is the primary treatment. If the owner refuses, then you can switch to the drugs that are mitotane and trilostane. Another important point that was mentioned in vet prep was ketoconazole. It can also be used as a treatment drug for Cushing's because it inhibits production of all steroids. So it can be used. It's cheaper, and it is given if mitotane and trilostane, both the drugs are not tolerated. Mainly, the most important drugs that we need to remember are mitotane, trilostane. For adrenal tumor, again, surgery is the best option. If not, then you can switch to drugs. And the last is treatment of iatrogenic Cushing. For iatrogenic Cushing, there's just one treatment. You need to stop corticosteroid injections. So stop giving steroid drugs that led to Cushing. Lastly, the adverse reaction to mitotane is gastrointestinal signs. Mitotane, if given in a large dose, it can decrease cortisol to an extent that it will lead to Addison's disease. So we need to take care about that. And you can perform ACTH stimulation test. If mitotane led to Addison's disease, then you need to stop mitotane and treat with prednisolone or other steroid. And mitotane toxicity will cause CNS signs like stupor, circling, ataxia, etc. So that is why it's said that the safer alternative to mitotane is trilostane. Trilostane will block synthesis of both cortisol and aldosterone because it it just blocks the synthesis of steroids, and both cortisol and aldosterone are steroids. Last important point that was mentioned in vet prep was Cushingoid animals develop fatal pulmonary thromboemboli due to hypercoagulopathy, which means hypercoagulable state. If you remember, cortisol was overall favoring clot formation because it increased platelet function, it increased clotting factors, it decreased fibrinolysis or clot breakdown. So overall, it helped clot formation. So if in Cushing's, what will happen? There's excess cortisol. That means hypercoagulopathy is seen, and this hypercoagulopathy will predispose to fatal pulmonary thromboembolism. That's it. This is just a separate point mentioned, and we need to remember this. The other 2-3 diseases that are important for Navle, we are done with the endocrine system, but the other diseases are Sertoli cell tumor, diabetes insipidus, pheochromocytoma, which is the tumor of adrenal medulla. Just know 2-3 lines each. That's all for the endocrine diseases of dogs. Thank you.